Well, g'day everybody, it's Brett Mitchell from Infection Control Matters. I'm at the ICPIC Conference in Geneva. I'm in the innovation section of the posters. I did try and record some things using a device that Martin gave me, but unfortunately I couldn't get that one to work, so I'm using my phone. Hopefully it's okay. One of the posters here is from Hugo Sax's group, and it's called Tracing Hand Pathogen Transmission with a newly developed DNA-encapsulating Lipid Nanoparticle system. The idea is to be able to identify how pathogens are spread in healthcare settings, and they developed a lipid nanoparticle encapsulating DNA as a surrogate for pathogens, and it's susceptible to hand hygiene. It says that the lipid membrane is dissolved by a disinfectant while leaving the DNA intact. So I'm assuming that disinfectant perhaps is alcohol, and could well have other utility if that can be designed that way. And really the idea of this is to be able to use as a tracer system to enable fast and effective modelling of different transmission dynamics within the healthcare setting. And it probably makes it very practical for evaluating things like infection control practices and hand hygiene. I think it probably has some other benefits down the track as well. And it's great to see these new type of developments coming out. So well done to Hugo Sax's group. So I'm still at the Innovation Academy posters, and the second poster I wanted to talk about was from Jinsey Jerry and Derek McGarry from Ireland. And what they wanted to do was develop a FFP2 procedural mask that incorporated a self-sealing one-way valve. So basically you can allow endoscopic instrument access for someone who is wearing this particular mask. And there's also a transparent window on the mask, so you can facilitate visual examination of the mouth and the oral cavity and improve communication. So this modified FFP2 mask does meet the filtration standards of the EN standard for filter efficacy. It's at 99.36%. I think it's got some amazing value because you can keep healthcare workers safe while performing those types of procedures, and at the same time enable that safe examination of the oral cavity and also improve communication. So I've done some pilot testing of this as well, and patients and healthcare workers have reported positive experiences. So really an innovative mask which is going to have some important value for medical procedures and in pandemic situations and in high consequence infectious disease scenarios. And the third poster that I was going to pick up is by Pellet from Switzerland, and it's a new medical mask made of filtering and a transparent eco-friendly material. So they developed a medical mask that is transparent to improve communication between healthcare workers and patients, and it meets the EN standards 14683, and it also is developed from an eco-friendly material. And that's particularly important when we saw in COVID-19 just how many masks were being used and thrown away or ended up in wasteful. So this is going to be a great mask to be able to restore the visual and facial expressions and empathy and trust and all those effective communication pathways that were lost when masks are being used, and provide that relevant protection that a medical mask would provide, and at the same time having some compostable material. So fantastic work. And the final post that I wanted to talk about was one from Altieri, and it's called AI for Healthcare Associated Infections. And the idea of this is to develop an AI-assisted 360-degree visual audit that turns that sort of routine imagery into rapid objective insights. So just think about those routine audits that are often manual and time-consuming. You can use this computer AI approach, and you walk through, and it's able to analyse and detect alcohol-based hand rub at the point of care, PPE availability, bed spacing, waste handling, service integrity, and the detection rules come from the evidence in a matrix that's been developed. They're geolocated and documented snapshots, and then they provide outputs including a heat map, which is a sort of a concise guideline-linked action list of things that it identified as being potential missing or problems. So it can pick up missing alcohol-based hand rub, unstocked PPE carts, overfilled clinical-based bins, cracks in surfaces. So I think this is an amazing development and example of how AI can be used to proactively and quickly monitor many process things that we look at in infection control and audits that are undertaken. And we could do this much more scalable and much more efficiently with the use of AI. So fantastic, interesting piece of work. That's it from me from the posters at the Innovation Academy at the ICPIC Conference.
Hello everybody, it's Martin Kiernan here, and I'm at the IPS Conference wandering around the posters, and I come across one called Developing the Infection Control Assurance Framework, ICAF, a pathway to enhance IPC practices. And I managed to find the author, which is Frances Butson, and she works at Gloucestershire Hospitals NHS Foundation Trust. Now, Fran, thanks for agreeing to talk to me for a start.
Thank you.
Now, board assurance frameworks traditionally go up the organisation.
Yes.
So the infection prevention team and others will do an assessment, and the board will review it, and they then will do something, possibly. Yeah. But you've done it in a quite different way, haven't you? Can you explain firstly, because we have an international audience, what an infection control assurance framework looks like, and then how you've gone about getting a bit more of a ground opinion in your organisation?
Yeah, absolutely. So what we've done with developing the ICAF was to take some themes. So obviously standard precautions, which includes things like hand hygiene and personal protective equipment, patient placement, risk assessment, PPE usage. Water safety is another category. And then other infection control practices, screening, sampling, and cleaning as well, domestic provision, nursing cleaning, mattress and cushion care, and finally posters. So the aim of this is to very much kind of put the infection control responsibility back into different areas' hands. So there's an inpatient ICAF, there's an outpatient ICAF, and there's theatre ICAF. So they're all slightly adapted to each area. So it's set out in an Excel document currently, and each area has to score whether they are compliant with the questions on the ICAF.
Okay, so they'll do their own local assessment of how well they comply with the framework.
Exactly.
So who does it?
So it's a bit of a mix all over the place. Some places have their ward managers do it. Some places will have an infection control link nurse, for example. And some places like to do it that they split it into different parts and they get different people to do it, just try and get more people, as many people involved as possible, really.
Would it be the same person doing it every single time?
Not necessarily. Not necessarily.
Probably a good thing.
Yeah. So again, there was when I first introduced it, I said, this is something for you. You can choose to do it how you want to do it. I'm not going to police it. As long as you're doing it and you're gaining something from it, then you can do it however you like. And whether you want to have an HCA involvement as well, for example, is fine by us. Getting everyone involved, really. So it could change every month.
Okay, now this means that the staff actually understand what good practice should look like. And they probably a bit more ownership. So how are the staff responding to actually being asked to do this? Are they asked to do it, or are they told to do it?
They're told to do it. We have every 3 months we have an infection control committee, and they have to feed back their compliance on there. So they are required to do it by the infection control team. But we've had, I'd say, a relatively good response to it. We've had a little bit of resistance in the beginning because it is something to get used to, and there are audits attached to the main ICAF as well, which cover things like water safety, mattresses. So there's some resistance, but I think now we're 7 months in, they're really kind of getting on board with it and really taking it into their own hands.
Okay. And what are you doing with the information then? Presumably you collate it all, and then are you getting organisation-wide themes, or are you finding areas to target where action's required?
Yeah, so I mean, again, in terms of the responsibility, so we're asking areas to take that ownership and to be in touch with us if they need any help with anything, if they've identified any areas that they might need some help on. Or
so this is turning you from the police to the fire brigade, isn't it? They identify their own problem, they ask you for help, rather than you going in and say you've got a problem.
Yeah, exactly.
Sort that out.
Yeah, absolutely, because we didn't want it to be a sort of pointing fingers and blame culture. So we wanted them to recognise it and try and take action with it on their own.
Now, what happens if I mean, presumably there's like a RAG rating, red, amber, green?
No,
Oh,
there isn't.
okay.
No.
I was just looking at the picture on the poster, and it seemed to be
Yeah,
inappropriate.
no, the colours are just to make it a little bit more interesting, to be honest.
Okay. So how do you identify areas this is really concerning, even if that area hasn't picked this up as a concern, you think it is? How do you pick up on those?
So in the first 6 months, so I've been going through it regularly because I've sort of created it, and I've had follow-up meetings and things like that. So because we're so ward-based and we go out and about a lot of the time, you know that there are issues in places anyway, and that's reflected in the ICAF, so then we can work with them on it.
Okay.
But because there are so many areas, I think there are over 150 ICAF sections, it can be quite hard to keep on top of.
Yeah.
So that all kind of feeds into how we want to develop it in the future to make it more automated data and things like that.
Okay, so sometimes a particular statement may suit some areas well and some areas not quite so well. Is this helping you pick out that actually this doesn't really fit for that department, like theatres, etc., therefore we need to modify it to make it more relevant?
Yeah. So I 3 months in after we started it, I sent out a questionnaire asking a range of questions. Do you find it useful? Is there anything you don't think is relevant? Is it changing your practices? Is it engaging more people? And then I did a series of meetings where I just invited everyone that wants to or is completing the ICAF for asking for their suggestions on what they'd like to be changed, what's not so relevant, etc., and then trying to make changes from that. But we're trying to not necessarily make it very set to one specific area. That's why we separate it into inpatients, outpatients, theatres, because we find that some places might want to have a very specific question, which we can't necessarily do. We need something generalised but set into those categories.
Okay. I suppose there is an opportunity for a supplementary framework that is part of the main framework, but so that people can look at their own specific areas.
Exactly. And I think that's something that people have potentially developed as well. They've developed their own ways of doing things, their own little audits, and for a nursing cleaning checklist there's no sort of set thing that we provide them, and they've often created their own, and they're always very good, but it's obviously dependent on their area and how they've worked as a team.
I mean, I noticed you got on the poster nearly 2/3 of people said the questions weren't relevant to the area of the work. Is that at the beginning, or are they starting to say, actually, it does apply? I haven't really thought of it in that way.
So that was at the very beginning. So this survey was, it's introduced in April, and this survey was in May, when they were very much getting used to it. But then that really helped to inform me to make the changes that I needed to make, which I still continue to make because it takes a lot of time.
Yeah, I'm sure.
It's very time consuming. So, it's learning for me and for them. They can kind of see how they might need to actually be considering these things. But then I also can consider, that doesn't really apply to them. I need to adjust that.
So a lot of give and take, which is, I think, a very beneficial thing.
Yeah, definitely.
Now, you've also got a podcast in the organisation, which I think is fantastic.
Yeah.
Tell me a bit about the podcast.
So the podcast is run by me and my colleague Jen, who is a senior infection control nurse at Gloucester Hospitals. We started off doing a vlog, decided the video life wasn't for us, so we switched over to a podcast. So our podcast we do every month, and we have a number of guests, and we discuss anything and everything IPC related. So we've done series on different microorganisms. So we've done for example, like a CP episode, C. difficile episode. We've done things like mouth care episode, winter preparedness, all of the above really, and down to antimicrobial stewardship. And we're currently working on doing one sort of a day in the life of an IPCN. And hoping to get some of our other colleagues involved, a day in the life of an antimicrobial pharmacist, for example. But
you're also using it for, disseminating the findings from the framework as well, which is
absolutely
a good, easy way for people to get some understanding of what's going on.
Yeah.
Do many people listen? Do you know?
The numbers are picking up. Then they're still relatively low, but we get around 200 a month.
That's not bad.
It's not too bad for a first go, and we're getting more confident every time. So we're really...
Is it freely accessible?
Yes, it's really accessible. So it's on YouTube, and there's also the option of Spotify, Google Play, or whatever it's called. So we've got an amazing team at Gloucester Tools that are our sort of tech team. And
the comms people do it for you.
Yeah, comms
Very
people.
nice.
So they have a platform called Acast where it gets put onto a number of platforms like Spotify and etc. So we'd always appreciate a listen.
Yeah, well, no, we'll certainly highlight it.
Yeah.
It's called Infection Control in Action.
Yes.
Don't forget there is no space between the two words, because otherwise it makes it look like you're not doing anything.
Exactly.
Well, thanks very much for chatting to me, Fran. I really appreciate it, and good luck going forward.